Good morning to one and all present here. So today's topic that we will be seeing is object localization and intensifying screens. So the concept of object localization is very important, especially in two-dimensional radiology. So in two-dimensional radiology, where you take IOPAs, bite wings, and occlusals, there are certain concepts like object localization, where you will be able to take the single X-ray in different ways. And this is done in order to localize certain objects or certain lesions which you will not be able to see otherwise. So basically, the indications for object localization technique is to find out the location of foreign bodies, any instrument separations, any salivary gland stones, any canal position, or any accessory canals or lateral canals which are not visible, and root pieces or fragments which have been let out after an extraction, filling materials which could have been present in the periapical region, and any broken needles or files or any instrument separation, and also superimposition from the adjacent teeth. So, this is the basic diagram which talks about object localization. So this technique is also known as the slope technique, which is nothing but same side lingual and opposite side buccal. So which means that we take two consequent X-rays. So the first X-ray is taken with a particular horizontal and vertical angulation, and a second X-ray is taken with a mild tube shift. And this tube shift is done so that we will be able to see the presence of that image which we want to locate. We will be able to see the object which we want to locate. So here, how do you shift the tube? So when I'm shifting it towards the same side, I can see the objects which are present lingually. And when I move the tube to the opposite side, we can see the objects which are present on the buccal aspect. So this technique is also known as the Clark technique and tube shift technique. And the principle of this entire technique is known as the principle of parallax. So once again, when an object is viewed in two different positions, the object appears to move in different directions. So we have to compare the final IOPA images of both the images which are taken with the technique, and then we can find out the actual position of the location of the object. So these two radiographs are nothing but they are known as the reference radiograph and also the second radiograph. So these are taken consequently one after the other. And the second radiograph will be definitely taken with a mild change in the horizontal or vertical angulation to make sure that it is not mimicking or not being the same or exact reproduction of the first image. It has to be mildly different so that we find out any changes or any what is the different distance between the surrounding structures, adjacent structures, all that can be noticed in this particular second radiograph. Okay, now this is the main concept once again, where we can find out that the dots which are given in red color are objects which are present lingually, and if the dots are given in green color means that the objects could be present on the buccal aspect, and the different X-ray beams which can be given accordingly is seen over here. Okay, so next we have the right angle technique, where two projections are taken at right angles to one another. So both the images are definitely intraoral, but they will not be the IOPAs. One X-ray will be an IOPA and the other X-ray will be a occlusal radiograph. So the IOPA can show us the inferior and superior relationships, anterior and posterior relationships, whereas the occlusal mainly shows the facial and lingual relationships and also the anterior and posterior relationships. Now coming to intensifying screens, this is again a very important 5-mark question for the final years and the third years. So these are the different parts of the intensifying screens which are given in this diagram, where we have a base, a reflective layer, a phosphor layer, and a protective coating. Now, about 30% to 35% of the X-rays which are striking the screens interact with these screens, producing a large number of visible light photons. The use of intensifying screens helps us to reduce the radiation dose which come to the patient. But one disadvantage of using intensifying screens is slight blurring of the final image. Now, what are the types of screens that are currently being used? So we have fluorescent screens. Under fluorescent screens, we have calcium tungstate screens, gadolinium oxysulfide screens, and lanthanum oxybromide screens. So these oxysulfides create a green light and lanthanum oxybromides create a blue light. And historically, most commonly, most of these were used and other phosphors and rare earth elements were added later on. And the second type of screens are fluorometallic screens, where the screens feature a lead foil between the film base and the fluorescent layer, thus enhancing the overall image quality. But in spite of that, we have to accept the fact that they will be blurring and reduction in the resolution of the final image. So this is the double screen cassette which we normally use in the sizes of 8 inches, 10 inches for taking extra oral images and also for taking OPGs, and they are embedded with the intensifying screens. Thank you.